Good morning, distinguished guests and colleagues. It is my honor to speak with you. Thank you for joining us at the KSERS 2026. I sincerely appreciate your presence and your continued commitment to advancing minimal invasive surgery. As our society goes to age, understanding how surgical practice evolves in elderly patients has become increasingly important. Today, I will present our study titled Minimally Invasive Surgery in Elderly Population in Korea. I have no financial interest or industry support to discuss regarding this presentation. Let me first show you the trend in elderly population in Korea. As you can see on the left, the proportion of individuals aged 65 and over has been steadily increasing and is projected to rise sharply in the coming decades. Korea is expected to become one of the most rapidly aging society in the world. On the right, you can see the demographic shift more clearly. While the total population remains relatively stable, the elderly population continues to increase, whereas the working age population is declining. These demographic changes has important implications for surgical practice, particularly in managing elderly patients. This demographic shift has a direct economic impact. The medical expenses for the elderly accounted for nearly 45% of total healthcare spending in 2024. The monthly average medical expense per elderly person has steadily risen, reaching approximately $415 in recent years, which is nearly 3 times the average for the total population. This slide highlights the Korean government's policy response to our rapidly aging society. As the graph on the right illustrates, Korea's elderly population is projected to exceed 40% by 2060. To address this profound demographic shift, the Korean government has continually strengthened its legislative frameworks. These continuous measures represent our national commitment to supporting an aging population. What defines old age? While 65 is traditionally chronologically threshold, we must consider biological and functional age. A marathon runner at 80 can be biologically younger than chronologically ill person at 50. This perspective is crucial when we evaluate a surgical candidate. However, aging is also a matter of mindset. Here you see the renowned OBGYN doctor and the founder of Chosun University College of Medicine, Gileo Lee, at age 80, and the fashion designer Vera Wang at 74. They demonstrate the personal mindset and lifestyle can significantly influence the biological aging process, challenging our traditional views on chronological age. Now, let's look at the physiologic changes during the aging process. As people age, many body functions gradually decline. For example, basal metabolic rate, heart rate, and lung capacity tend to decrease over time. Muscle mass and bone strength also reduce, which can affect the mobility and overall health. On the other hand, some factors like blood pressure and body fat may increase with age. Understanding this baseline is vital for perioperative management. This slide summarizes findings from 2021 study on treatment pattern in patients aged 40 and older with hepatocellular carcinoma. On the left, the table shows that THCE has been the most commonly used treatment in this age group. This likely reflects concerns about surgical risk in older patients. However, the survival curve on the right tells a different story. Patients who underwent surgical resection had significantly better overall survival compared to those who received TSE or other treatment. So, while surgery offers better prognosis, in real-world practice, TSE is more frequently chosen, largely due to age-related consideration. This slide shows the rapidly increasing number of surgeries among elderly patients. Comparing data from 2004 to 2014, we can see the significant rise across all age groups. In patients with their 60s, the number of surgeries increased dramatically, and the similar trend is seen in those in their 70s and 80s. Even in patients aged 90 and over, the number of surgery has noticeably increased. This trend suggests that age alone is no longer a strict barrier to surgical treatment. Improvement in surgical techniques, anesthesia, and perioperative care may have made surgery safer and more accessible for older patients. This chart shows the overall pattern of a surgical procedure in adults aged 65 and older. Cataract surgery is by far the most common, followed by spinal and joint-related procedure. Other surgeries such as gallbladder and cancer operation make up small portion. Overall, most procedures focus on the improving quality of life, especially vision and mobility. Moving on to specific procedure, this slide breaks down the annual volume for gastrectomy and colectomy among the elderly based on the 2024 NHIS yearbook. As expected, the total number of both surgery gradually decreased as age advanced from 65 to 85 and older. Understanding this demographic variation is crucial for planning tailored geriatric surgical care. If we look at the patient aged 65 and older, they account for about 56.4% of all gastrectomy cases and about 53.9% of all colectomy cases. Here we see the annual trend for appendectomy and thyroidectomy. While overall volume for both procedures naturally decline with age, their gender distribution is contrasted sharply. Appendectomy are predominantly performed on the older males, whereas thyroidectomy are significantly more common in females. Unlike the previously discussed surgical procedure, minimal invasive surgery cases for appendectomy, cholecystectomy, and herniaplasty are collected separately. Let's first take a look at the appendectomy. Overall, the number of appendectomy cases decreased with age, and the laparoscopic surgery is dominant approach across all age groups. Patients aged 65 and over account for 18.5% of laparoscopic cases. Among patients aged 65 and older, 90% of all appendectomy were performed laparoscopically. Next is cholecystectomy. Cases peak in the 65 to 69 age group and decrease with age, with laparoscopic surgery as dominant approach. Patients aged 65 and over account for 34.6% of laparoscopic cases. Among patients aged 65 and older, 92.4% of all cholecystectomies were performed laparoscopically. This slide shows a trend of herniaplasty, including laparoscopic procedure. The highest volume is seen in the 65 to 69 age group, with the numbers gradually declining with age, but remaining substantial overall. For laparoscopic herniaplasty, patients aged 65 and older account for approximately 47.8% of all cases. Notably, among elderly patients, only about 43.2% 4% of hernioplasty procedures are performed laparoscopically, which is markedly low compared to cholecystectomy and appendectomy. Is MIS safe for elderly patients? The answer is resounding yes. Laparoscopic and robotic surgery demonstrated complication mortality rate comparable to younger cohort. The major advantages including reduced surgical trauma, less blood loss, and decreased cardiopulmonary complications. Importantly, oncological outcome remains comparable, making these approaches both safe and beneficial for older adults. However, we must be mindful of the physiologic stress caused by pneumoperitoneum and extreme positioning. Increased afterload and decreased lung compliance can strain the stiff myocardium or poor gas exchange capacity in the elderly. Head-down positioning raises intracranial and intraocular pressure, which is risky for patients with neurologic or eye disease. Renal perfusion may also decrease, increasing the risk of acute kidney injury. To reduce complication, we should keep insufflation pressure low, adjust positioning gradually, and limit extreme positioning. This slide outlines the first part of optimal preoperative assessment for geriatric surgical patients based on the guidelines from the Journal of American College of Surgeons. Beyond the routine history and exam, focused assessment is key in elderly patients. We should evaluate cognitive function and decision-making capacity, screen for depression and delirium risk. It is also important to check for alcohol or substance abuse. Cardiac evaluation should follow the standard guidelines, and we must identify the risk factors for postoperative pulmonary complication. These steps help optimize outcome in geriatric surgical patients. Continuing with the preoperative assessment guidelines, several additional assessments are crucial in geriatric surgical patients. We should evaluate the functional status and the fall history and calculate the frailty score. Nutritional status must be assessed, especially in high-risk patients. A detailed medication review is essential to manage polypharmacy. We also need to clarify the patient goals and expectations, assess family and social support, and order target preoperative tests to optimize outcome. The Frail scale is particularly useful screening tools. By assessing fatigue, resistance, ambulation, release, and weight loss, we can categorize patients as robust, pre-frail, or frail. This score helps predict postoperative outcomes and plan necessary intervention. This study evaluated the perioperative outcomes of robotic surgery in frail elderly patients. Among 982 patients, 7% were classified as frail. Frail patients had significantly higher rates of major complication and mortality compared to non-frail patients. Advanced age, higher BMI, and poor performance status were also associated with worse outcomes. The findings suggest a frail elderly patient face greater surgical risk, highlighting the importance of careful patient selection and through the preoperative assessment. Before sharing our work on severance experience in adults aged 70 years and older, I would like to express my sincere gratitude to professors and colleagues who carefully compiled the material and data for today's presentation. In particular, I recognize Professor Nareun Kim, Professor Seong Kim, Professor Yunmin Kim, and Professor Sung-Yun Yang. Their dedication, hard work, and collaboration made this comprehensive review possible. This slide compares the longitudinal trend of surgical approach for gastrectomy and colectomy. For gastrectomy, we see the steadily shift from open surgery toward the laparoscope and robotic approaches, reflecting advance in minimally invasive technique. In colectomy, laparoscope surgery has become the dominant method, with robotic surgery steadily growing over time. These patterns suggest a broad shift toward minimally invasive technique, through the phase of adoption varies depending on the surgical complexity. In contrast, hepatectomy shows a slow but clear increase in minimally invasive adoption, with robotic cases emerging more recently. For pancreatiodynectomy, open surgery remains predominant, but minimally invasive approach, including laparoscopy and robotic, are gradually increasing. Overall, these trends highlight the role of technology in improving surgical outcomes and expanding treatment options. Here we compare the minimally invasive surgery with open surgery for major hepatectomy and pancreatiodynectomy. In major hepatectomy, MIS significantly reduced blood loss and shortened hospital stay, while complication rates are similar. For pancreatiodynectomy, MIS also shows a low blood loss, short hospitalization, and a significantly low rate of clinical relevant pancreatic fistula. Overall, MIS demonstrates clearly perioperative advantage over open surgery in elderly patients. I will briefly present the outcome of radical surgery for periampullary cancer in octogenarians. In our cohort, many patients could not undergo surgery due to advanced disease or poor general condition. However, those who received radical surgery showed significantly better overall survival compared to non-surgical management. This benefit was particularly notable in patients with common bile duct cancer. These findings suggest that with careful selection, surgery can provide meaningful survival advantage even in elderly patients. In octogenarian, we observed the trend in surgical approach for gastrectomy and hepatectomy over time. For gastrectomy, minimally invasive technique, particularly laparoscope and robotic surgery, have steadily increased, while the open surgery has decreased. In contrast, hepatectomy cases were fewer overall, but we still see a gradual adoption of minimal invasive approach in recent years. This trend suggests growing feasibility and acceptance of less invasive surgery, even in very elderly patients. In summary, the demand for major abdominal surgeries, our aging society is growing. MIS is a safe and highly effective strategy that facilitates accelerated recovery and maintains oncologic safety. By combining meticulous preoperative assessment with minimally invasive techniques, we can ensure the best quality of life for our elderly patients. Thank you.